and they still survive that journey, becoming more resilient. With the example um, I showed it to you, they are much more fitter than many other cells, and I'll show you some weaknesses they have as well in the tutorial, hopefully today. You can also see this similar journey taken by these cells. You can see melanocytes sitting inside the body. As a result of migration, you only find melanocytes on the skin. You can see some spindles, the blood forming, sorry, the milk making cells sitting in brains. And you can see also these colorectal cancer cells sitting in a liver as a result of taking this long journey, as I was mentioning to you. So for organism, of course, this is not a good news because it kills those patients. Sadly, all of them would have died of their disease. These are from probably from also autopsy samples, definitely these ones as well. So they need to be extremely fit. And that's a good news for us because in order to become trained to be at that level, it takes a very long time. In fact, in many of them, many of us never develop cancer. So, how many roughly develop cancer? I think every three individuals in five, so 60% develop cancer, and rough estimates are that 40% are killed by cancer. So, why this is needed? They need to be highly, highly resilient to carry out this journey into distant organs. These cells were never meant to be here, but they are actually surviving here and killing the patient. So cancer cells actually they have a lot of barriers to cross. They need to be extremely fit in order to migrate from their primary organ to distant organs. And this migration is, you can show here, this is shown as these athletic games or a swimmer, which is trying to swim away from a shark, I believe. They need to be extremely fit. In our body, the shark will be none other than our immune system, which will try and stop them in their tracks. So they need to defy a lot of odds in order to carry out this journey and come to this stage. So when I'm saying defy odds and migrate, metastasize, what am I talking about? I'm talking about what is shown on your next screen here. You can see what these cells are capable of. As epithelial cells, as I discussed yesterday, they form surfaces of different ducts. They form surfaces of our skin, uh, different organ surfaces. And you can see here, they're meant to stick together. They have a glue called cadherins, E-cadherins. I'm sure many of you know E-cadherin proteins. And their primary role is to stick the cells together on an epithelia, forming a covering. That's what they do. But these cells are undergoing these changes. Uh, is there any question? I heard someone. Padmavati, do you have any question? Okay, sorry. So what is happening here? They were meant to stick together and form the covering in order to protect the inner surfaces, inner linings of that organ. They're not doing it. And you can see here the normal cells shown in yellow, but these cells which have the primary mutations, these are the cells which have the initial DNA damage. Sadly, the repair system failed. They were not able to see these. And what will happen? They will have certain mutations in them. These mutations will allow them to perhaps outgrow the other cells. So you can see here, these cells, there must have been a single cell in shown in blue. They are overgrowing now compared to the other cells. So they're already showing rebellion. They are not really following. They should not be growing as they are growing at the moment. They are starting to grow more. This might require mutations. And trust me, you go and have a look at any cancer. There are hardly any cancers in which there are no mutations. You will always find mutations in cancer cells. provided your sampling is correct. So what happens here? That's fine if they are growing, but what happens over time when they accumulate one mutation after the other? Imagine this cell, the initial cell which I was showing you, they were not able to correct with this monster face I showed you, an emoji. They were not able to correct the defects that they have. And because they cannot correct, they have first mutation. Chances are that they will have more mutations because they have run out of the repair system. If they have the mutations and they are allowed to grow further, what can also happen is that they can start attracting the blood vessels. In fact, they can in fact start to make their own blood vessels supply, a process we call as angiogenesis. So they're capable of making their own blood supply in order to escape the primary site. In fact, there is a recent paper which came, I don't want to quote a wrong paper, but it shows that if you treat primary tumor, sometimes you can promote metastasis. I'm not saying don't treat primary tumor, but have a look at that paper. I think that paper came in Cancer Cell. I might be able to find a reference if you need. But have a look what is happening. You need these cancer cells to be much more fitter, like those birds, migratory birds I was showing you. They have lots of adaptations, as you know. So what happens next is that they start to invade. They are not meant to melt the connective tissue underlying where they were sitting. They start to melt the connective tissue. Specific enzymes they have. Have you heard of metalloproteases? Many cancers overexpress. They have more metalloproteases. And they're basically melting anything, any connective tissue, any stroma that come in their pathway. What are they trying to gain? They're trying to gain access to the body highways, which are our blood vessels. Because if they can gain access to this, they can go anywhere in the body, anywhere where the blood will take them. Sorry about that. And what is needed in order for them to make these metalloproteases? Epithelial cells don't make it, but these cells gain a property to make those metalloproteases. And do you know why this is happening? Because the genes were already present. They were epigenetically, as Dr. Aziz was telling you yesterday, and Dr. Hibs or Siddiqui will tell you, I think tomorrow or day after, that there are epigenetic changes. So genes, specific genes are switched on in cells, specific genes are switched off. We all know this as being selective gene expression. We know there are pancreatic cells, specific cells in pancreas, which make glucagon, which make insulin. Not every cell can make insulin in our body, can it? No. But the gene for the formation of insulin is present in every cell because the genome is constant. Every cell has the same gene set. It is only that those genes are not expressed. But what these cells are doing, they are expressing those genes, and by doing so, they're able to melt these connective tissue, gain access in the blood. What are they going to encounter in the blood? Lots of cells, from lymphoid cells, lots of immune cells, lymphocytes, which should attack these cells and kill them. And yes, believe me, it happens. So although the first cells might have been formed, pathologists take a look, very dense chromatin, it looks like cancer. It may still be very differentiated, meaning that may not be an advanced cancer. So what happens for cancer to form this, for cancer cells to gain access, for cancers to survive this journey into the blood, and for cancer cells to go and sit? And these are not whole big lumps of tumors, they're single cells moving. It requires mutations after mutations after mutations, which make them fitter. And as a result of this, what can happen? They can gain ability to sit in lungs and grow. They prefer bone a lot of time because then they can hide sometimes from the immune system. But more importantly, bone is very high in nutrition. Almost 80% of human tumors have been reported to metastasize, to take this journey and sit in bones, exactly like those birds I was showing you who are going from cold, harsh weather, winter from Siberia into the summers of Asia, for example, doing this journey. And some of them actually might sit in a brain because in all of them, their own perpetuity will be guaranteed. And once they reach these organs through blood, they need again the capacity. So remember, these cells are changing their not only their behavior, but they're expressing specific genes. How this all happens, we don't know. We know very little about this. You see some papers being published every day, um, which would show some of these characteristics of cells becoming cancer, carrying out this invasion metastasis cascade. But how it happens in a live human being, we are far from knowing this. And in the end, what happens here is these cells can go and sit in different parts of the body. So that is the entire journey completed. And you can also appreciate these epithelial cells are different. These are more like mesenchymal cells when they're flowing in the blood, and then they regain their ability to sit back in the target organs where they metastasize to. This transition has been dubbed as a epithelial mesenchymal transition. Um, And you can see here what is happening in epithelial mesenchymal transition is that this is the tumor mass. And I'd want you to focus on cancer cells. Shown here, you can see here, these are cells undergoing from epithelium becoming mesenchymal, meaning they're growing legs in order to move out of this organ. Demand for nutrition, right? They move out because of this. They want to proliferate, they want to grow, they want to take hold of other lands. So what they're doing, they're moving out of their primary organ, they're melting the connective tissue, gaining access of the blood vessels, going into the new organs, for example bones, where they're full of nutrition, and establishing their colonies in distant organs in order to metastasize. You can see it probably as like British Empire, leaving very cold, harsh island of United Kingdom, Britain, and settling in many parts of the world at the expense of the local population and enriching themselves from it. This is a perfect example of this. You can see this in that way. But you can see it didn't happen overnight. It requires a lot of changes in the DNA to make them fitter, where they're able to change from being the epithelial cells into being mesenchymal cells, and then from this state, these cells being able to travel and survive into the bloodstream, and then going back into their epithelial form and start forming tumors at the expense of the local population of cells. Can someone say that they can hear me? Yesterday we lost connection and there was no one who. Swati, am I still audible? Okay,
Yes,
thank you very
you
much.
are.
So you can see this. Thank you very much, Dr. Aziz. So you can see this is not an ordinary journey. It requires each step of it requires these cells to become fitter. As someone of my age, I suspect I have some of these cancer cells already, given my parents' cancer, died of it. May have these cells, but I don't want you to get worried, but see what happens. We have a very good system that keeps us safe. They need to have lots of mutations, right mutations, that will not only make them grow at the primary site, but actually be able to metastasize. Each of these events will need new set of mutations. Of course, if you have one mutations, there will be more chances to have subsequent mutations in the same daughter cell as it divides, but that will take time. So the essence, the crux of this happening cancer, it needs to have enormous level of replication events. And that replication event will allow it sometimes to accumulate right set of mutations which are needed for the cancer cell to carry out this entire journey shown on this slide. So where do you think you would see more cancer forming? We have different cell types. Have a look at this slide. Okay, this paper came, I think Nature, sorry, the reference is missing. You can see on your screen, on this y-axis, there is a lifetime risk. Lifetime risk is going up for different cancers. And on x-axis, you're seeing the stem cell divisions. Where do you see the most stem cell divisions in FAP, this specific colorectal cancer that Dr. Aziz's lab studies. You can see that we have a very high lifetime risk of developing colon cancer because they are the ones which divide the most. And of course, division takes very, very long time. So if you're dividing, if you're a cell who divides by tendency a lot, then the chances of having this division and accumulating those mutations is much more higher compared to those cells, for example, these pelvis osteosarcomas, head osteosarcoma. You will have to go cities to find cases of these cancers because they don't really divide. And as a result, the lifetime risk of developing such cancers is much more lower. I was showing you that Nature paper which came about the air. Sorry, is there any question, Dr.
Yeah,
Aziz?
I have a question here that always
Yeah,
bothered. What,
sure. Sorry, I lost you. I think you're mute.
sorry, what about the pediatric cancers? Cancers in the
Excellent question you have asked. So, do you see any pediatric cancer on this slide? Uh, for example, retinoblastoma and so on. So all of these cancers you're seeing, they have very high division or low division. Pediatric cancers are usually exceptions because, for example, in retinoblastoma, the cancer of the retina, back of the retina, you have just one mutation in single gene. Sometimes in retinoblastoma gene, RB gene itself, that's a single mutation that causes that good gene to lose the ability to control a transcription factor, which is E2F. I'm not going to the detail as yet, but I will. What happens there is that they are inborn, they are germline mutations inherited from parents where there is just single mutation. They don't have any other mutations because the cells have not divided at all. And eye cells, retinal cells, for heaven, don't really divide so much. But those mutations which are found in babies actually can lead to development, abnormal growth of the cells in the back of the retina, and they can actually migrate into the areas near the head, not migrate, but invade into the local areas. So as such, they don't have very high cell divisions in them, but they're still capable, not because of the tendency to accumulate mutations, but because there is a very important tumor suppressor missing. And that is why, because they don't have a very high mutation load. Mutation load simply means that as the cells divide, they accumulate more and more and more mutations in subsequent daughter cell population. That is not the case with pediatric cancers such as retinoblastoma or some forms of lymphoma. And that's why they're very easy to treat given the right doctors and clinical access. They can be very easily treated because the background tumor load is next to negligible. Does that answer your question, Dr. Aziz?
Yes, absolutely. Thank you.
Thank you. Yeah, that was a brilliant question. So you can see here, someone has to be really, really, really unlucky for having cells which are able to move out from this to this place and manifest itself into cancer like this. Now, I want to highlight something. As you can see, myself hail from India. Is these adverts? This I'm going off the topic, but think about people trying to make their skin color fairer. Who is? Do you know who gets melanomas in UK? People with my skin color don't get melanoma at all. It's a natural protection. What people are trying to do is becoming more fair in color, and this is actually a societal problem. We should be proud of what color we have, and in fact, the darker we are, the chances of having melanoma through the sun rays is minimal compared to the white population. So we should be content and grateful actually that we are born with this color. Many of us, it's very common. The more south you go, the color changes. Should not impact anything, but what we should avoid is all these skin penetrating chemicals. Cortisone knows what is there in these chemicals, which can lead to cancer, which is not yet studied. So coming back to the topic, you can see here these cancer cells need to cross a lot of barriers. The more they divide, the more they can become fitter. And as a result, what happens is cancers where the cell division number inherently is much more higher, there is a very high lifetime risk. And that's why you can see here, in order to reach this number where the cancer cells are actually uh, gone through a lots of cell division, it requires time, meaning patients need to become aged. And as you can see from this chart here, the incidence of cancers actually don't increase tremendously until we are old. And why this? Because it allows cells to buy the time to accumulate mutations in the daughter cells to carry out this journey, and that I'm showing you that somebody has to be really, really unfortunate to have a cancer diagnosis. What we are doing on top of our natural system, those mummies develop cancer, right? I showed you yesterday. So one way or the other, we will pass. We will never be. This is not the permanent home we have, right? The word. So what we are trying to do by exposing ourselves to these chemicals, cigarette smoke, alcohol, is accelerating this process coming from here to here. Which is very sad, in fact. And the paper I was showing you, this Nature paper, which has the air quality index shown, would you be surprised? This paper shows in one of the diagrams that the findings that these cells which are exposed to the pollutants actually divide much faster. That's a bad news for a cell which has been left with mutations to divide faster, because then it is going to accumulate mutations at a much faster rate than a normal epithelial cells or any other cell type given. So that is sad news. Uh, so here we are. I think I have covered this. Uh, Dr. Aziz, are there any questions? I'm happy to take questions, or I can carry on. I don't want knowledge overload, so it becomes less interesting to
They don't see
each
anything
one of
in
us.
the chat box, but their microphones I'm turning on so they can speak and
Yeah, if you have questions, please feel free to ask.
so yeah, your microphones are on, so please go ahead.
Yusra is asking, can we provide the study notes of today's and yesterday? Yes, Yusra, I will send it to Dr. Aziz. The notes from the
I
yesterday are
already
ready, and the ones from,
Dr. Asim, I already sent you the
sorry,
Google folder, so you can just
yeah,
upload
oh,
it.
that's correct.
Just
I
upload
will
them
upload it there. Yes, I will do
to
that.
mine as well, and we'll provide you the link so you can access it anytime.
Great. I have to say this is a superb initiative by Government of India to have programs like this so that we can all learn together. Brilliant ways to learn. And I hope by the time our lectures, both Dr. Aziz's and mine, will finish at the end of this week, uh, you would have made your mind, is this something that you want to pursue as your career, research on cancer? And definitely if you don't want to do that. So, okay, I'm not seeing anyone asking questions. Are you happy for me to carry on, Dr. Aziz? And then I can stop. So you can see here, this is a model of cancer. Well, the question just
You
came,
can
so
have
I'll
a question.
stop and take. Sandeepan is asking a question. Can modern gene editing techniques change the fate of these mutating cells with age and prevent cancer? Sandeepan, that's an excellent question. Are you a faculty or are you a student? Please let me know in the chat box. Sandeepan is asking a very good question. Can we change, meaning can we reverse those mutations and make a cancer cell a non-cancer cell? Sandeepan, theoretically 100% possible, but to implement this even in a laboratory setting, to do it in vitro in lab, it will be difficult. Changes, there will be different changes, like Dr. Aziz was showing yesterday. Some people think they're sitting on an elephant, they think this trunk, those ears, they are the cancer. Other things that these pillars are cancer. First of all, what are the driver mutations? We need to know those driver mutations. Oh, you're a master's student. Excellent. Congratulations on your knowledge and your understanding, Sandeepan. So, coming back to the topic uh, of your question you're asking, you need to know what are the driver mutations. Some mutations are passenger mutations. They're just there because the pathway to repair them is not there. So how many of them you're going to change? You know the cost of gene editing, how expensive this is going to be. It is going to be enormous effort for any health economy, especially health economy in India, to do anything with gene editing for cancers which have very high mutation burden. Yes, something you can do for diseases like retinoblastoma, where you know exactly which gene to revert back to its wild type phenotype. So that makes a perfect sense for cancers where there will be less mutational load to be able to change at the level of at the embryonic level to make those changes. But for diseases like this, when an individual has been smoking for 40 years straight and they have enormous changes to their DNA, reverting them back each time doing CRISPR, you know more than me, Sandeep, when cancer cells are not usually diploid, they have tetraploidy, they may have hypertetraploidy. So, how many alleles are you going to revert back to their wild type phenotype? And we're talking about if not billions, millions of pounds to be spent. And again, you're treating a body which has already been exposed to a lot of different threats. So I would say this will not be viable. Giving you an example, gene therapy, people thought when it came, oh, this is going to be super viable. But now, you know, many people think that gene therapy is not something which can be rolled out to masses of population. Having said that, there are hopes for genes where we know exactly what mutations are there, which can predispose. So if you can make interventions before cancer happens, for example, mutations in BRCA, which we very well know, might predispose patients having those mutations for specific forms of breast and prostate and other cancers, you can certainly do those interventions. So brilliant question. Um, I have seen another question. And Dr. Aziz, if you want to add something, please feel free to do that to the answer I gave.
Uh,
Uh,
I had a more optimistic approach, Sandeepan, because we are already
okay.
seeing success stories coming in, like sickle cell anemia was successfully
Yeah,
cured, and even in the rare diseases, we are finding this because rare diseases are
that's correct.
really difficult to treat. So people are going for this, and
I
as
totally agree.
but yes, economy is one aspect that we need to definitely consider. Plus, in cancer, it's multifactorial. Coming back to the same point that it's not one mutation, except for there are some exceptions. Mostly, it's multifactorial, and it's a
That's right.
moving target. So you diagnose it today, you go after 3 4 months, you have got the target has moved. So that's why
That's
it's not
right.
going to be able to treat cancer. Thank you.
No, I totally agree. And on top, for diseases which are non-cancer, for example, thalassemia and so on, you know exactly what is the mutation causing these sickle cell-shaped RBCs to form. And in those cases, certainly you can do such interventions. That's much more straightforward than we're talking about cancer. You can see there are enormous mutation load in most of these cancers, which will be a nightmare for any pharmaceutical industry to use gene editing. Uh, I'm not talking about when I said I'm not pessimistic, but what I'm saying is the best disease treatment we have for prostate cancer, advanced disease, is a drug which has been used, sold to Johnson and Johnson, I think, for $8 billion, $8 billion, and it gives 3 to 6, 7 months to live. Now, I asked the question who discovered this drug in Memorial Sloan Kettering. I was in a talk and he was presenting. And I asked him this question more than 15 years ago, that why would I want to live? These patients who have this advanced disease, the cancer has gone into bones. Why do you want to keep me alive when I have such excruciating pain? The disease is really terrible. It cracks open the bones, causing enormous amount of pain in bones. And his answer was, well, some people can see their grandsons, granddaughters graduate from high school. They want to live. They don't want to die, basically. That's what he was saying. So even if it can at 3 months, uh, the US government is happy. The insurers are happy to spend. millions of dollars to treat one single patient. That was his response. So it is all in the perspective. I told him, if I have this disease, I would rather not want to be alive and give more trouble to myself and my family for another 3 months. So anyway, coming back to the questions that are in the chat box, Dr. Aziz, feel free to take any of these. I'm going to read them. Any specific reason Khadija is asking prostate cancer chances increase after 40 years? One of the things that we have discussed, Khadija, is the rate and the time a cell has undergone cell division. So if cells undergo more division, you are older, your cells are more old, and the chances that they have accumulated more cell divisions increase, but also the time that you have been exposed to agents, cigarette, alcohol, those creams, God alone knows, as I said, what is in there. Is there anything causing cancer? Then certainly chances of this increase as well. Zaid is asking what happens to cancer incidence with increasing age. As we discussed, Zaid, they go up, as I mentioned, with age for almost every cancer. This is the same trend. Mustafa is asking, will these interventions, treatment therapy, will be more expensive like the mainstream? Yes, that is the problem, Mustafa. These drugs, which we can make for pennies, are being sold because they have patents. They're being sold for much higher price. Then certainly doing CRISPR using gene editing, the treatment will be super expensive on an individual basis. We already do treatments for CAR T cell therapies. Uh, uh, Many of them are not even permitted, even in UK. As you know, the there is no private health system as such, and the population, local population, relies on government hospitals for treatment. Many of them are not really available to us because the evidence is very little that they increase lifespan, a healthy lifespan. Aparna is asking, can we not use stem cell therapy when diagnosed at the first stage of cancer? When diagnosed at this first stage of cancer, benign cancer. Well, stem cell therapies, as you know, are used. You deplete from the bone marrow the cancer cells and then replant populated cells which you grow in culture. You can make those interventions, and yes, that saves life. Certainly, that's I don't see any issue with that. So, Aparna, yes, but to roll it out in a big population and make sure that developing a drug and then following it up through a longitudinal follow-up, 10 years, 15 years, it takes time, and many of the treatments we have unfortunately don't really stand the test of time. Many times these treatments may have severe adverse effect which will kill a clinical trial of a drug, causing lots of closures of companies. So that's not a good news, of course, but yes, that is one aspect which has become a treatment in specific cancer cases, certainly. So we have 7 minutes, and I'm trying to see what I can complete. So on this slide, what you're seeing is again the same thing. The cancer cells is becoming fitter. This is called multi-hit model of cancer induction, which suggests that cancer actually does not happen overnight, and it takes a long time. And why it takes a long time? Because the cells have to be really, really lucky. Cancer cells, I meant, they need to be really, really lucky to have these first mutations, which will give them growth advantage. Second cell mutations may give them advantage to grow more uncontrollably, or may be able to, for example, other mutations may be able to give them more chances to move inside the tissue, for example, invade in the sorry, without mutations. And that need mutations that will give them that quality, that ability, that they're able to migrate. There may be fourth mutation. So this is oversimplification. Don't think there are just four mutations. And the fourth mutation will make sure that they can escape into the bloodstream and survive. There are enormous levels of mutation in a cancer cell. Sometimes not just one gene mutation, multiple genes mutated. And as Dr. Aziz was telling yesterday, pathways are important. there may be whole pathways switched on or switched off, which will allow them to survive in their journey when they're going from the primary organ to sit and metastasize to a different organ through blood. This journey may take very, very long. We now that we have epidemiological data, we have data from lots of patients, especially in Western countries. We now know some hotspot mutations. We know TP53 is a good guy, is a good gene which is